am pleased to be the moderator for today's final session of today's afternoon. And so we're here for the Federally Qualified Health Centers and Evidence-Based Health Promotion, Disease Prevention, Intervention from Practice to Policy. So I'm going to introduce very briefly the two speakers for today's session, but I do invite you to look in the agenda to read their full bios. So our first speaker is going to be Kelly Horton, and she is the Research and Policy Specialist with the National Council on Aging, or NCOA as we know it, the Center for Healthy Aging, which is based here in DC. And then our second presenter, who's going to be Howard Bedlin, and he's responsible for all of NCOA's federal and state legislative advocacy efforts on issues and programs of concern to older adults. So that includes Older Americans Act, Medicare, Medicaid, long-term care, income security, and community service programs. So these are our two presenters, and without further ado.
I'm going to talk a little bit about the National Council on Aging and our Center for Healthy Aging's health promotion and disease prevention public policy efforts, and the importance of reaching older adults through community health care centers and why we find that important. And then we're going to learn about some key provisions in the Affordable Care Act that can be leveraged to promote referral to and funding of evidence-based healthy programs, and then also explore policy recommendations that expand access and sustainability for be leveraged to promote referral to and funding of evidence-based healthy programs, and then also explore policy recommendations that expand access and sustainability for providing these programs through the community health center system. I tend to talk fast, so if you have a hard time hearing me or understanding me and want me to slow down, just kind of make that motion and I will do that. So just a little bit of background. Throughout the day, you've probably met people from NCOA. We're really excited to partner with the group providing this conference. But just to make sure we're all on the same page. So our mission at NCOA was re-strengthened last year, and the mission is to improve the lives of millions of older adults, especially those who are vulnerable and disadvantaged. And when we were talking about vulnerability and disadvantage, we are looking at health issues and economic issues. So people who are living around the federal poverty level, people with multiple chronic conditions. And we do this work a lot by working with the community organizations. So we're really excited to strengthen our partnership with community health centers over the last year and a half. And the main crux of our work is to look at creative solutions and then bringing those creative solutions to the attention of policymakers and trying to get funding for those solutions to be scalable across the country. Our main goals are also in accordance with a lot of the health centers that are working with seniors, is to help seniors live independently, find jobs and benefits, improve their health, and remain active in their communities. So just to start with some statistics that many of you are probably familiar with, by the year 2030, there will be over 72 million older adults, and we define that as age 60 years plus. If you looked at 60 years plus, then it would be even more. And that's a doubling from the year 2000. And by 2020, minority elders will make up 1/4 of the adult population. So we definitely need to look at what are the services that are needed for those populations. Many of the health centers already serve older adults. And I just want to point out that even though the national average that we hear talked about a lot is about 8%, many of the healthcare centers serve about 30% of their clients are older adults. So when we look at like we look at Vermont, I think they have like 32% of their clients are older adults. And I was actually just at the National Association of Healthcare Centers Subcommittee on Aging meeting, where there was over 30 healthcare center directors there, and many of those healthcare centers were serving upwards of 20% of their clients of older adults. But the minority of FQHCs have engaged in the Aging Services Network, and many feel really unprepared how to handle those health issues. So that's why we're here today, having the conference. So for those of you who are here today, you're the green fish. You're leading the charge of all these other healthcare centers, and the work that you do with aging is really going to start to set an example and provide information and research examples and innovative solutions that other healthcare centers can follow. Isn't it great to be a leader? Okay. So we want to collaborate strategically with you, help really look at these solutions and what can we do to improve the lives of older adults. And why are we really concerned about health of older adults? Again, NCOA is really focused on the person with chronic conditions. If you look at the statistics, we can see that in 2000, 125 million Americans had one or more chronic conditions. It's projected to increase by more than 1% every single year through the year 2030. That's a huge percentage of our population. And of course, we hear the statistics every day that the baby boomers are retiring at an average of 10,000 people a day. That's an average. I've heard that it's upwards almost 12,000 on some of the days. So that's a lot of people entering this demographic. So people with chronic conditions account for 84% of healthcare spending. This is all from national data. And as you can see, that's a big chunk of the pot. In some of the other sessions that already happened today, people were talking about politically what's happening. And this is the chunk of the pot that politicians are talking about, that are really taxing our healthcare system. In 2006, 28% of Americans had 2 or more chronic conditions. And you can see that almost 5% of the population had 5 or more chronic conditions. So I used to work at a healthcare center. Our average population had 6 to 11 chronic conditions, and trying to manage those conditions was really a complex situation for our dietetics team. Older adults are more likely to have multiple chronic conditions. Those conditions don't tend to go away. You just tend to get more of them as you age. So this graph is really looking at what's happening age-wise, and for people over 65, it's about 91% of the population have 1 or more chronic conditions, and just over 73% have 1 or more chronic conditions. What's particularly alarming is if you look down at the younger generations, those numbers are just going to get larger, which is what I was just talking about. So we do hear the Administration on Aging actually starting to talk about across the lifespan. And we see the government agencies really trying to work across the lifespan because we can just see these numbers coming. Looking at hospital stays, folks that have multiple chronic conditions are more likely to have inpatient hospital stays. And I think we all know that. And a lot of folks with multiple chronic conditions, if they don't get the primary care, then they are the ones that are really going into the emergency rooms, causing a lot of healthcare expenditures there. I'm going to move through some of these. So what are the chronic conditions we're talking about? There's 5 chronic conditions that account for 1/3 of the Medicare spending: diabetes, arthritis, kidney disease, hypertension, and mental health behavioral issues. And just eliminating 3 risk factors, so eliminating poor diet, inactivity, smoking, those would prevent 80% of heart disease and stroke, 80% of type 2 diabetes, and 40% of cancer. So there's a lot that we as individuals and as communities and nationwide can actually do to prevent these from happening. This was a chart that was put together by some of our colleagues at the Partnership for Chronic Disease, and we adjusted it for people over 60. And this is just the amount of money that's being spent to care for folks. It doesn't include the the indirect cost. So folks not being able to work, calling in sick, their caregiver having to be sick, their family member, whatever. It doesn't include Alzheimer's, because the Alzheimer's number that we have includes all of those costs, and we're trying to, if you have a number that's just direct care costs for Alzheimer's, we would love to get that and include that on here, because that is a huge chunk as well. And sorry for that little snafu there. So in our Center for Healthy Aging, we are focused on multiple chronic conditions. We're also focused on behavioral health, which is part of that. And just wanted to point out a couple of things. 25% of people who are age 55 and over experience some mental health disorder, and that can include anxiety, cognitive impairment, mood disorder, that are not really part of the normal aging process. And nearly 1 in 5 Americans 65 and older experiences some symptoms of depression, and this can really impact whether or not they seek health care, whether or not they implement the health care recommendations they've been given. And then another component of our work is falls prevention. So I know that there's been there was a falls prevention in the mental health there's a falls prevention session earlier today, and I think there'll be a mental health session tomorrow. There's a falls session tomorrow. So I'm not going to spend too much time on it, but also falls contribute to nearly $30 billion spent annually on treating people with the effects of falls. And if we could do preventative health promotion programs, self-management programs, we could probably really dent that number. So one of my colleagues used this in their presentation a while ago, and I just love this. The older gentleman saying, "Honestly, Doc, if I'd known I was going to live this long, I would have taken better care of myself." It's just perfect. We all need to take better care of ourselves, but we need a system that helps us take better care of ourselves. And we need a system that helps doctors proactively refer people to that system. So some of the forces that promote healthy aging, we look at, there's the chronic conditions, and then there's poor quality, high cost of health care, there's frustration around the healthcare system, and then there's the evidence about what works. If we give people the tools and the knowledge of how to manage their condition, and actually I really liked it in the previous session, she's not in here, but she talked about, why don't we talk about managing wellness rather than managing the chronic condition. So it's really, managing chronic conditions is helping people feel empowered, and managing wellness would really turn that into sort of that positive frame. I like that a lot. Some of the principles of healthy aging, number one is prevention. I'm sure most of you understand that. All of you probably. We all know if you prevent it, then you don't have it happening. So health, self-management, self-determination, evidence-based outcomes, community-based collaborative solutions, and also challenging ageism. So I remember a couple years ago we were talking about why do we look at over 60, why do we look at over 50? And that was really generated when the government decided you were no longer a productive part of society. We know that's not true anymore, right? So how do we challenge ageism and make sure that folks are given the tools to remain part of society and contributing and have a full and happy life? So the good news is we can do that through health promotion and disease prevention programs. They've been proven to help people have a longer life, reduce disability, improve mental health, and lower health care costs. And Howard is sneaking in here now.
I'll sneak all the way.
Come on up.
Sorry. Transportation issues.
We're glad you're here. Okay, so one sort of the frame that we look at National Council on Aging is the Aging Network. And how many people here are familiar with the Aging Network, that term? Okay, great. So for those of you not familiar, this is a great network to tap into. The Administration on Aging helps to lead the Aging Network, and the Aging Network, it consists of AAAs, the Area Agencies on Aging, which are in every community across the country, and also the ADRCs, which is Aging and Disability Resource Centers. And these are really the leaders in your state and in your community that know what's happening with the aging population. And there are several states, such as Oregon, Massachusetts, Washington, where their aging network is already partnering with the FQHCs and really trying to make sure that the senior that comes into the health center gets the services that they need, or gets a referral if the health center can't handle their needs. So if you're not working with the providers within the aging network, that is the first place to start, is figure out who are the aging providers, how can you partner with them. And the aging network really has grasped onto this evidence-based activities. So through the Administration on Aging, there is funding for chronic disease self-management, which many of you have heard about today. There's funding for quite a plethora of programs. I'm going to show a list in a little bit of evidence-based programs. And these are programs that have gone through studies and have shown that they do produce outcomes for older adults, as well as actually other age groups. So some of the programs that are included, that are funded through the Administration on Aging, are A Matter of Balance, which helps with the fear of falling, Active Choices, Active Living. So there's some physical activity programs in here, fear of falling programs. There's some nutrition programs. There's mental health programs. These are all programs that are being offered through the Aging Network. And depending on where you are and what community you're in, they may only offer one of them. They may offer a few of them. One of the big things that the Aging Network is actually asking itself right now is, when we get somebody into chronic disease self-management, how do we get them referred to a falls program if that's what they need? How do we get them referred to a nutrition program if that's what they need? And I think healthcare centers can really play a pivotal role in that. And most of these programs, not all of them, are offered through a peer leader who has that a chronic condition themselves. So it is somebody identified from the community who has taken this program and really taken it to heart and is able to talk to people in their community about why this program works and really get them motivated to change their lives. So here's a map of those programs across the country that are supported by the Administration on Aging, CDC, CMS, Department of Education, HRSA, Veterans Administration. So this actually only shows 4 of the programs. There's the CDS&P, Matter of Balance, Enhanced Fitness, and then Healthy Ideas, which is a mental health program. So you can see there are some states that are offering several of the programs. And at NCOA, we've actually just gone through a mapping process to look at in, let's say, Ohio, where there's a couple of programs being offered there. There's 3 programs being offered. Are those programs all being offered by one health center, or are they being offered by several health centers? Are they being offered by several senior centers? Is there any linkages? So we're starting to try to do those linkages, and that's really the next step of program sustainability for us. This is just a quick map. I think you might have shown this in your other presentation, so I won't go through this. But this is the CDS&P reach by county. And Christy, I think, went through the outcomes. So if you were in the CDS&P session just a few minutes ago, you know that it does achieve some really great outcomes. And people in CDS&P have multiple chronic conditions. The other thing with what we're doing around falls is we have the Falls Free initiative. I think Lynn has already left. So I think if you were in the Falls presentation, she would have talked a lot about this. If you weren't in it, the basic bare bones of that is that it's actually 41 states now that have coalitions for falls prevention for older adults. And in those coalitions, there are some of the coalitions that have partnered with community health centers and made sure that those are a part of that conversation. So if falls prevention is an issue that you want to take on, I do suggest you get in touch with the Falls Free Initiative, figure out who the coalition is in your state, and really get connected with those groups. And those are so it's now changed. What's the other state that we had to pencil in? Indiana?
Utah is new, and this map is interactive and has state profiles at ncoa.org/fallsmap.
Thank you. And then around behavioral health, we now have a new senior vice president at NCOA's Center for Healthy Aging who is very interested in behavioral health, and we'll probably see some more activity in this area in the next year or so. But right now there are 2 programs that we have highlighted, Healthy Ideas and Pearls, to help people manage their depression care. So I'm going to turn it over to Howard actually to talk about. So that's sort of the backdrop. What are the programs? What's the issue? Why are we supporting evidence-based programs? And now I'm going to turn it over to Howard, and we're going to talk about what are the policy opportunities that we really see for community health centers and others in the aging network to promote these programs and find funding for them.
Good afternoon. Sorry I was a little late. That fell off. Thank you. So I think part of the reason that we're all here in Washington, D.C. is because this is where all the decisions, not all, but most of the decisions that the federal government makes, kind of a scary proposition these days. And as you all know, health reform passed a couple of years ago amidst great brouhaha and controversy, which hasn't ended yet. However, whether you liked it or not, it does have a lot of different provisions in there that many believe provide opportunities for better value for the healthcare dollars that we spend, for a lot of innovative things that can improve our delivery systems, and we believe also include a variety of provisions to support evidence-based programs for older Americans with multiple chronic illnesses. So we're going to walk through a number of opportunities that we've identified, some of which are in the Affordable Care Act and some of which are not. Some of them include trying to improve self-care. You know, as I think Kelly may have said, one of the things that we sometimes say to policymakers is even those who utilize a great deal of health services they're only interacting with a healthcare professional 1 or 2% of their time, and what happens with the other 98 or 99% of the time, and particularly with close to 10,000 baby boomers turning 65 every day now. Many of them, including myself, are much more internet savvy. As soon as we go to the doctor and get a diagnosis, we come back to the internet and search to see what's on there and whether or not there may be someone else that we might talk with. Much more engaged, I think, in self-care than, for example, my parents are. So there are a lot of opportunities there for self-care and greater engagement as we look into the future. A lot of these programs, as Kelly's mentioned, are community-based. We think the opportunities for savings, in part, are because it doesn't necessarily involve a physician. Certainly, these are things where we're hoping to keep people out of hospitals, keep people out of emergency rooms. And we also think they lend themselves to web-based solutions, again, looking into the future and where we hope that older Americans are going to be more engaged in taking care of themselves both before and after they experience some kind of health problems. Ooh, got it. So we're going to look at 6 different opportunities. First is Center for Medicare and Medicaid Innovation, which is part of health reform. And I'm tempted to ask everyone in the room to raise their hand who submitted something already to the CMMI. Sometime around this town, it seems like everybody has seen this golden opportunity, billions of dollars for innovative programs, some real interesting things that they're doing already, and we think some great opportunities down the road. So we'll talk a little bit about that. One of the provisions in health reform had to do with prevention under the Medicaid program, which is now the biggest health insurance program and is going to get bigger, and some states are really stepping up to the plate. Community health centers, we think we're looking to really partner, work closely, collaborate with them, and there's some great things happening around the country in certain centers. One that is near and dear to my heart as a policy wonk and lobbyist, don't hold it against me, is the Prevention and Public Health Fund, because that is very controversial these days. Just a couple of days ago, on Friday, for example, the House of Representatives proposed to repeal it to pay for reductions in the rate of student loans. Actually, the student loan rates are proposed to go up because of an expiration, and in order to pay for those, House Republicans have proposed again, I think this is the 3rd or 4th time, to repeal the Prevention and Public Health Fund. But there are a number of provisions in there that we've been working on to get additional funding for some of these evidence-based programs that we'll talk about. Community transformation grants, again, a lot of public health programs happening in state and local areas, funded in part by the federal government, where we think there are a lot of good opportunities. And then sort of outside of the Affordable Care Act, work that the Administration on Aging and CMS are doing on community-based prevention and wellness programs that we hope will give us some evidence that will lead to many of these programs being taken to scale. Because as you can imagine, in the current budget climate, the first thing when you talk to people on the Hill is any new idea, how much does it cost and how are you going to pay for it? So the degree to which you can show return on investment, savings in the health system anywhere else is extremely important. And it's problematic because of lack of data on occasion. So we're hoping that this evaluation will give us some of the data that we can really use to show some not only positive outcomes, but cost savings as well. CMMI, as it's commonly referred, in this area, lots of acronyms. This is one that you should become comfortable with because it's a big buzzword. It's almost as big as ACOs. But it is an area where there is lots of money to spend on innovative ideas, and they have to show some kinds of savings. They have a very good dynamic website where you can submit different ideas into a portal. They're launching various campaigns around innovations challenges and partnership for patients to get folks around the country interested and mobilized. And as you can imagine, and you know far better than I do because I'm inside the Beltway and you guys are mostly out in the real world, there are some very important programs that are working very well that can be taken to scale and are good candidates for some kinds of demonstration projects. These go beyond demonstrations because they're much more easily turned into national programs and taken to scale. It's not like the normal CMS process, 1115 waivers is what they're generally referred to under Medicaid, that can take years and years to get started, lots of regulations, long evaluations, and after 10 years, you're still waiting to take it to scale. The purpose here is to do it much more quickly, get the evidence, and try to turn it into successful programs across the country. Accountable care organizations were really the first one out, and many are hoping that the way they're structuring the incentives and looking at who's bearing the risk, it could create some improvements in outcomes and cost reductions. So we're looking closely at how these are going to be working. All of us are hoping as we launch into a big debate nationally over Medicare reform, which is another way of saying how much to cut Medicare, that we can look to improvements in delivery that will make the program more efficient rather than having to shift more costs onto beneficiaries. So we're hoping that these will move quickly, have solid evaluations in them, and really show some evidence that they are working well. So we're hopefully optimistic. Section 4108 of the Affordable Care Act, which they issued regulations on, I think it was last year, is giving grants to states to really look at health promotion, disease prevention programs. And we were very involved in working with a number of states. Kelly, I think it was close to a half a dozen that actually did include the chronic disease self-management program in their proposals, and they're now implementing them. So, as you can imagine, for CDSMP, which we think has a great deal of evidence both within the United States and in other countries as well, trying to find sources of funding to take these programs to scale is a major part of what we're hoping to do, and this is sort of the Medicaid piece of it, where just like our work with community health centers, you get a few early adopters, leaders, whether they be provider entities or plans, or in this case states, that get out front, are more prepared to really implement some of these programs, hopefully have a good evaluation component. You get successes in 5, 10 good models out there, and then it attracts others to replicate those in some form. So kind of not unlike CMMI, the theory is if we can provide real-world evidence about how these programs are working, that will, again, provide incentives for, in some cases, Medicaid, in other cases, health plans, maybe even Medicare at some point in time, to try to pay for some of these different programs through various structured incentives. Community health centers, as we mentioned, Kelly and I worked with the National Association of Community Health Centers to put article in their journal or newsletter, which Kelly can talk to you better than I can. Again, sort of outlining what CDSMP is and pointing to examples in a number of states with particular FQHCs who are taking the lead here. Similarly, trying to look at those who are on the cutting edge of really doing some innovative things and trying to bring in some data and show that there are positive results and should be replicated. My guess is that more and more there are going to be a lot of low-income seniors who come into community health centers. They're already treating folks that have multiple chronic conditions, and I think there is a great interest in looking at these kinds of evidence-based, community-based programs that really can reduce cost or at least be cost neutral when you look at the programs that people go through and the potential for savings in terms of reduced hospitalization, reduced hospital readmissions, which you know is a big concern, and reduced emergency room visits, et cetera. Prevention and Public Health Fund. This is actually the next step from a provision that was included in the stimulus package back in 2009. Senator Harkin, who is the chairman of the Health, Education, Labor, and Pensions Committee from Iowa, created this fund in the stimulus package. And we were able to get some funding for the CDS&P programs, which enabled us to take it to about 48 states. That funding, however, expires this year, and we've been trying to get funding through the Prevention and Public Health Fund, which he was able to include in the Affordable Care Act, very similar in terms of its intent with regard to looking at community-based prevention across the age spectrum. And last year, we worked with his office and some of our champions, particularly in the Senate, and the Administration on Aging worked with us as well to include $10 million for the CDS&P program. And we were very pleased that that survived the final cut. And we had also worked quite a bit to try to get falls prevention into that same package. As Kelly may have mentioned, we've been doing a great deal of work over the years, have found that it's prevalent, that it's very expensive, costing about $55 billion in 2020, and it's largely preventable. There are a number of evidence-based programs that have shown that falls can be reduced and that you can save significant dollars. So we were very pleased when actually we got both of these included in the Senate appropriations bill in the Prevention and Public Health Fund. But then in December, when the final deal, so to speak, came together and the Senate negotiated with the House, we were disappointed that we were disappointed that the falls prevention dollars got stripped out. We were pleased that CDS&P survived. Falls prevention dollars were taken out. There's still $2 million in the Centers for Disease Control, their National Center on Injury Prevention and Control, that does include some funding for falls, but this is a currently $28 billion program, and we spend $2 million to prevent them. So there is quite a discrepancy there, and we're going to go back, as you could imagine, and try to get the Senate again to step up and include this $10 million. The problem is this is very controversial these days. It has been, the fund itself has been referred to as a slush fund by House Republicans for the most part. I think part of that criticism is due to the fact that there are certain CDC programs whose budget was reduced within the department, and that some of the funding was then picked up in the Prevention and Public Health Fund. So it got cut here, and they moved it over to this other fund, and I think that's partially the source of some of the criticism, but it's mostly political. Anything that has to do with health reform right now is going to be controversial. Hopefully, after the Supreme Court decision, knock on wood, and after the elections, some of these proposals won't be so controversial anymore. It's interesting when you go to the Hill and you talk with a lot of Republican offices who have historically been very supportive of prevention programs. They'll tell you, we don't oppose this idea, but it's part of health reform, so we have to oppose it. So again, hopefully after the elections, things will ease up a little bit. The real problem right now with the Prevention and Public Health Fund, not only are folks in the House trying to repeal it, but the White House put it on the chopping blocks as well. In the President's budget, he was on the record for basically saying we could reduce this fund. And a few months ago, if you're following all of these crazy debates in Washington, you would have seen that there was an extenders bill that was enacted that not only provided for, this is back in December, an extension of unemployment insurance and a payroll tax cut, and part of it was the Medicare physician payment fix, one of those nice acronyms called SGR. It's the doc fix, and they, again, kicked the can down the road to next December, delayed it, the cut for another year, but needed to find a way to pay for it. So to make a long story short, one of the ways was a reduction in the Prevention and Public Health Fund. So they trimmed it by about $5 billion over 10 years. So instead, for example, of this fund increasing over time to go up to $2 billion, it's going to go more slowly. So for example, in fiscal year 12, funding for the Prevention and Public Health Fund was $1 billion. It was supposed to go up to $1.25 billion in FY13, but because of this reduction, it's flat funded for a year. So there's no new spending under this fund. That's going to make it more challenging for us to get funding for falls prevention, because we're going to have to find some program to trim that's already being paid for in the fund in order to come up with this $10 million. So it's a roller coaster ride. We need all the help we can get. As I mentioned, there was a big debate on Friday about using the Prevention and Public Health Fund to pay for this student loan extension of the reduced loan rates. And it was nice to see not only Senator Harkin stepping up and saying we don't support any more cuts in it, but the White House was very vocal as well. Secretary Sebelius, a number of House members really defended it. But at the end of the day, we do understand that there will be some agreement on this student loan issue. Lobbyists always have to look at the next fire we put out or the next mole that we have to whack. So a lot of attention is now on what's going to be the deal on the student loan program, because it's largely being funded by repealing the Prevention and Public Health Fund. The Senate and the White House also want to make sure to extend this reduction in the student loan rates. So we're going to have to come up with some way to pay for it. So again, we'll have a big fight, which is, pretty much what we do all the time around here. And hopefully it won't be part of the deal. My fear is that they may, again, trim it a little bit. I don't think the Senate or the White House will go along with repealing it, but, the concern is that they will add to that $5 billion that they cut back in December. So enough about the Prevention and Public Health Fund. It's been on my mind. I could go on, but I won't. Community transformation grants, actually very much linked with the Prevention and Public Health Fund. Again, these are programs at the local level. They struggle to find state and local money, so they are largely evidence-based. And these are funds from the federal government. Again, we see opportunities for these kinds of programs that are available in the community, largely, though not exclusively, through the Aging Network that can save money, improve outcomes. And the last provision I want to mention in the ACA was in, I think it's section 4202B, where there's this evaluation that is going to look at chronic disease self-management and Medicare beneficiaries specifically. I mentioned earlier that it's difficult sometimes to get really good data in order to show cost savings, and we have not, and others researching this have not had access to Medicare claims data that we could match in order to look at Medicare spending on a per-person basis. But we're very pleased that due to this provision, we will have that new data. We will be able to look at Medicare spending for this population. So we're hopeful that in another year or two, it's hard to say exactly what the time frame will be, that we'll have some really solid data. And in this town, the ultimate arbiter of all things health-related is the Congressional Budget Office. They're the ones who will tell you the fate of anything you want to do, whether your proposal is going to save money or cost money. So that's the bar that you always have to reach. And our gold standard is to have the Congressional Budget Office at some point in time say these programs are going to actually save money, because if you can show that, then members of Congress will welcome you with open arms and say, yes, we would love to fund your program because it's going to save money elsewhere. And that rarely happens, but that's our dream. And I think it's possible if you look at some of the data out there. Finally, I just want to talk a little bit about some of the other opportunities that we're looking at, primarily through the Older Americans Act, which is a program that really is the backbone of a lot of the community-based services that vulnerable seniors receive, but is not well known. People are more familiar with some of the programs under the Older Americans Act, like Meals on Wheels, services in senior centers. There are also jobs programs, caregiver support programs. It's very much localized, community-based, but it does wrap around a lot of the traditional health services that are available. And there are two parts of the Older Americans Act that have funded some of these evidence-based programs. One is the Title III-D program, which is focused on disease prevention and health promotion. It's only $21 million. And Kelly earlier described kind of the aging network. The money flows through the Administration on Aging to the state units on aging, to the area agencies on aging, of which there are about 650 around the country, and then to local providers. So you can imagine that $21 million does not go a very long way with 650 organizations who are in turn contracting with local providers. We've been stuck at $21 million for some time. So we're trying to use the money in the most effective way possible and have had some success, at least in inserting language into appropriations bills that these programs need to be evidence-based. So we're moving in that direction. We're trying to change the law to require that all these programs be evidence-based. Then we'll start turning towards how do you define evidence-based, which is a whole other session that we could talk about. But it's moving in the right direction, and we are, very much trying to show positive outcomes and greater value for every dollar spent, because dollars are tight. The other provision in the Older Americans Act is the part that is supposed to be funding innovations. And actually, there are a lot of programs that started out as demonstrations and experiments in Title IV and are now permanent programs in the Act, including some of the nutrition programs that I mentioned earlier. So we were able to get, in the Bush administration, under Assistant Secretary Josefina Carbonell, some discretionary dollars through this Title IV that included some evidence-based programs that looked at physical activity, looked at depression. It also included CDS-MP. And that was really where, a lot of these programs were funded for the past 10 years or so, 8 years or so. And the Administration on Aging has continued its commitment, but it's no longer funded under Title IV. Now it's under, as I mentioned, this Prevention and Public Health Fund. But we still think that Title IV has a very important role to play in terms of taking promising practices, taking some of the best programs available at the local level, turning them into a solid demonstration, not unlike CMMI. Actually, we're hoping to make some changes to Title IV so that it looks a lot like CMMI, taking those very promising programs, providing evidence, doing solid evaluation, and then taking them to scale. Unfortunately, because some don't think that we should be funding any new programs at all, and this provision of the law used to be where lots of members of Congress put their earmarks, and earmarks have been disallowed now. That's kind of the old pork barrel projects. This provision of the Older Americans Act actually got defunded completely for the first time in its history. So FY12 last year, it went down It was $19 million in FY11, $13 million in FY12. Wait a second, I'm behind a year, I apologize. Basically, in the last 3 years, it went from 19 million to 13 million to zero. So we're very disappointed, trying to make some changes, trying to emphasize the fact that this is a place where we can find some really promising programs that should be taken to scale, and we're hoping to generate some interest in this Title IV Programs Innovations program. Diabetes self-management education. There are a number of states who are doing some innovative things. Actually, Kelly and I are going to be talking to some of them tomorrow, where Medicare is starting to pay for some of these community-based programs. And we think, again, that this might be a good model that we could replicate. One of the things that I hadn't mentioned in the ACA that we also think is a good model that you're probably familiar with is the transitional care program, where trying to reduce hospital readmissions, where we're really starting to develop some partnerships between the aging network and traditional healthcare providers to reduce hospital readmissions. So we're hoping that can be a launching point for some, closer and in some cases contractual relationships between traditional medical system and the aging network and community-based providers. And this is another example in the diabetes area. And we're also exploring telehealth. I think, as Kelly mentioned, the CDS&P program is also available online. For some seniors who are homebound, they could benefit from this. That could be very important. We're very pleased now that Title IIID will permit states to pay for the online version of CDS&P. As I mentioned, as all of us baby boomers get older, I think we need to have two venues that people can access these services. Community-based programs that are easy to get to. Hopefully not the kind of transportation problems that I had today, but online as well. So, turn it over to you.
Sure.
Thank you.
Go ahead. Okay. Thanks, Howard. So just to sort of wrap it up before we get into questions, I should have fixed that, but that says make a difference. So we've talked a little bit about the Aging Network, and many of you weren't aware of the Aging Network before. And the Aging Network really is built on collaboration, and we really believe at NCOA that if we can promote the local, the state, national collaboration, and a lot of the policies that Howard was talking about, the success of getting those evidence-based health promotion programs for older adults funded is really through collaboration through older adults, the family caregivers, healthcare providers, researchers, and policymakers. And I'm going to skip over that. Okay, and so we're just going to move to questions now. Any questions that people have, we're happy to answer them. Or not. Know that Howard and just gave you a whole bunch of policy, and for those of you outside the Beltway, you might still be trickling through it, but go ahead.
I'm from Corporate Valley Health Center from Honolulu, Hawaii. We actually just adopted one more evidence-based program, Enhanced Fitness, besides the CDS&P that we've been running for about 2 years. Mm-hmm. So we received funding for Enhanced Fitness from, I think it's our money, and some of it is from state rainy day funds. So my question is, there any opportunity for funding in the future for Enhanced Fitness?
Sure. Well, for ARA funding, it was only for CDS&P. So maybe you use Title IIID funds for Enhanced Fitness, and you can still use Title IIID funds for Enhanced Fitness. We actually just did a survey, and actually Danielle helped with the survey before the law was changed. Now, Title IIID funds do need to be used for evidence-based programs, but we surveyed the state's units on aging directors and asked them which ones were already using their funds for evidence-based programs, and many of them already were, but also many of those state units on aging were also getting private funds, grants, local grants, state grants, and federal grants to pay for those programs. So and local fundraising as well. So there's a whole bunch of different ways that you can pay for the program, but Title IIID is available as well. Yeah. And Christy probably has more to add there.
Yeah, and I also wanted to know, and an individual in a presentation I was at earlier this afternoon also noted the value of community benefit for your local hospitals that have a nonprofit status. They are required by law to provide community benefit in order to keep that nonprofit status. And the way that many of them do that is through they issue RFPs or program announcements just like any other foundation, and they will fund programs within the community. So I do encourage you all to look into your local hospitals that have community benefit programs.
Absolutely. And if you have questions, I mean, I think there was, did we say 22 states, 24 states that filled out the survey. I know Hawaii completed the survey, so if you email me, I can put you in touch with the people in Hawaii who are already using private funds and foundation funds to fund our programs. Yeah. Did you have a question, Sue? Or a comment?
No, really a comment. I wondered if you wanted to go back to the diabetes self-management program that the pilot right now is looking at how to fund that through Medicare, and it is a DSMT, something that's available to the community health centers under fee-for-service. And in fact, I know in Detroit there is one of the community health centers that's the partner with the Aging Network to implement that program. So there is one piece that I think applies directly to community health centers.
Absolutely. And also Massachusetts is experiencing really good success with this. And there are other states such as Oregon who wanted to get the chronic disease self-management program included in its all-inclusive visit and had some stumbling blocks along the way. And those are the things that Howard and I are working on and actually sort of reevaluating what happened this last year and trying to help people get these programs funded. What can we do further with the Affordable Care Act and with the funding possibilities coming up in the future to really get these programs funded? So I know Massachusetts has actually worked out through AOA support how to get reimbursement for dietitian services and community health worker services providing the DSMP. Yeah. And are there other states that are, I know there's funding for 5 other states, but I don't know if anything's moved forward with those.
I would have to find out on that. I couldn't give specifics right now.
Okay.
Right now there's about 6, and it's not at the state level, it's at the Area Agency on Aging level, but there are 6. There's Illinois, there's, as I said, there's Detroit, there's one in San Diego, at least one in Texas, and might be another one in Texas, whether Chile in Texas. So yes, there are definitely places where it's being done, but I think the only community health center right now that's the partner, the Medicare
Is Detroit.
partner is Detroit.
And if it isn't in your all-inclusive, if it's in your state plan, then diabetes self-management can be included in your all-inclusive visit. If it's not in the state plan at this point, it can't be included. One of which would be great is if the all-inclusive visit could eventually also include chronic disease self-management, which would cover a lot more people. And then if that was in the state plan, such as some of these states that now have these grants are trying to include it in their state plans, then we would have more coverage. So those are some of the issues that we're really trying to focus on in the next coming year. Yeah. Other questions? You're all ready for 5 o'clock?